It's a small operation. Take 15 minutes. I'm going to take out your old implants and just do a fresh one. 5 to 10 years. Very different from the cosmetic world, I'm sure. But we have to be mindful that these things can gel leak very, very early, 2, 3, 4, 5 years, even after insertion. And we don't know the long-term consequences of that either.
Welcome back, every bendy body, to the Bendy Bodies podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. I am so excited to have this conversation today with Dr. Eva Nagy about breast implant illness. This is a condition that affects so many women, yet so often they are told that this is in their heads. This is really an important conversation, so I hope that you will really enjoy it. Dr. Nagy is the consultant breast surgeon at Sydney Oncoplastic Surgery. In addition to her medical degree, Eva has a PhD in biomedical science and a graduate certificate in breast surgery from the University of Sydney. She presents her research at international conferences and seeks to determine the underlying causes of systemic symptoms that affect some women with breast implants. I am so excited to chat with Dr. Nagy, and you may or may not have seen in my Substack newsletter where I talked about breast implant illness, but I actually was in the audience for an Oprah Winfrey show with women who had had breast implants. And at that time, I believed that breast implants did not cause systemic symptoms. I have, of course, since then completely changed my view. So I hope you will also check out my Substack newsletter on this topic, where I explain the incredible 180 that I did with my own personal thought process. Dr. Nagy is joining us from Australia, so I do want you to know that there might be some tech issues and a little bit of background noise at times during the conversation. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Be sure to stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Well, I'm so excited to be here with Dr. Nagy, and we want to jump right in and talk about breast implant illness. So can you start out by telling us, what is breast implant illness?
So I think the first thing that I have to say is that it's a legitimate disease. I cannot tell you how many times women come into my office and, just legitimizing the fact that they have an illness as opposed to the fact that it's in their head is a massive game changer to begin with. They see specialist after specialist, and they keep saying, oh, look, you're just anxious. You're not sleeping well. You're not exercising. Go do that. Go have a happy and healthy diet, and everything will be fine again. But it doesn't work that way. And so it doesn't fit into a nice little box of medicine. Everything has a little component, and it touches on every single facet of your body. Neurological, gastroenterological, your skin, your cardiac, your lungs. So which box do we put that in? If we don't have a box, well, we just say it's the patient. And so this is, think of it like you have a foreign material in you. Your immune system doesn't like it and tries every which way to try to get rid of it. And when it's unsuccessful in doing so, it ramps up and starts attacking your own body. Now, the more I start doing this and delving into it, more I'm starting to believe that it's mast cell activation syndrome. It's at the key part of it. So we all have mast cells, which are part of our immune system, and think of it like Pac-Man. They go along and gobble things up that are not you, whether it's bacteria, yeast, mold, virus, or foreign materials such as silicon. And when they get triggered by this, and the mast cells can undergo somatic mutations, so mutations that you acquire as opposed to what you're born with, congenital, they become more and more triggered by certain items. And so the silicon causes that activation, and the mast cells release histamine. And most people know about histamine, and we've all taken antihistamines at some point in time in our lives. When they do their job properly, for example, if you get a mosquito bite, it has local histamine release. You get redness, itching, pain, heat, to allow the blood vessels and the white cell count, the blood vessels to open and the white cells to come in and remove the toxin that has been injected by the mosquito. But when they go too rampant, when they get triggered too much, they release too much histamine and too many factors that they have. They have hundreds of factors that they can release, and it becomes systemic, gets circulated in the entire bloodstream. And so therefore you can have symptoms of any part of your body. So you get this systemic release of histamine and other factors, and then that brings about your symptoms. So this has been recognised. BII has been recognised from the FDA in October 21. Although they didn't call it breast implant illness, they call it a conglomeration of systemic symptoms. But it's the same thing. You can call it whatever you want. Breast implant illness is systemic symptoms, whatever it is, but it is an adverse reaction to a foreign material that's in the body. And unless you remove that foreign material, which is the implant, but also the capsule, because we see quite a higher number of patients who have silicone left in their capsule, despite the fact that they don't have a rupture. And if you leave silicone behind, you're still theoretically activating your mast cells. You still have the foreign material in you. So it needs to be removed intact and in one. So yes, it is a legitimate illness. Breast implant illness exists. It's not in your head. And it's an immunological reaction to the foreign material, which is the implant that's in you.
And are some women more susceptible than others? Do some women get breast implant illness and others are actually fine? And if they think they're fine, like, are they really actually fine?
So that's a good question, in that I'm not sure every single woman who has implants is going to get it. And we don't understand why but some women get it and some don't. We know that somatic mutations in mast cells is about 17 to 20% of the population, although I think that's an underestimation. But we have done a pilot study, which we've now expanded to about 150 patients now, where we see patients who say, I'm fine. No, I just want to get them out. I've had my fun with them. I'm 40, 50. I don't need them anymore. And they fill out the BII questionnaire. And when they actually go, we have 250 different questions trying to target different symptoms. And they tick and they tick and they think, hang on a minute, I am fatigued and I do have rashes and my gut's not particularly great, but I think it's all part of menopause, or I'm getting older. My kids are, very busy. My marriage is not so great. My job is really hectic. So they sort of explain it away. But it's not, I call it subclinical BII, I guess, because it's not a full-blown effect of the disease, but you still have some relative symptoms. And then when we remove the implants with en-bloc capsulectomies, they get better. And a lot of people say, well, it's psychological. Well, it's not, because it's not psychological that you're getting a rash, or you can't tolerate wheat and dairy, or you have frequent urinary tract infections or dyspareunia. They actually have legitimate symptoms. And so I think a large proportion of women don't actually realize they have subclinical breast implant illness and just assume that it's part of aging. But we've demonstrated quite a large number of women actually have an adverse reaction to the implants as a manifestation of that systemic symptom.
And when do the symptoms usually appear?
Well, that's interesting in itself, because if you take a detailed history, and I ask them, well, how did you feel when you woke up? Did you have a rash across your chest? Did you feel like you were hit by a bus? Did the fatigue come on very quickly and didn't resolve? I mean, you have to put into the context that they had general anesthetic and they might be nauseous and, they don't feel so great for the first few days, but that shouldn't linger. So in some women, you can actually have it as soon as they wake up. So one of my patients, she was very, very sick. As soon as she woke up, she had intense fatigue. She had a rash across her chest, which didn't go away. And she was on and off out of bed for about 3 months. And they didn't sort of tally it up together. She was kind of able to go to work, but that she would quickly come home and go to bed, sleep for as long as she possibly could. She didn't have the energy that she did. And she was, prior to that, going to the gym, very fit. So you can get it as soon as you wake up. It's an instant reaction. Or you can get it later on. So you can have it years down the track. We get people 5, 10, 15, even 20 years later on. Now, whether that's a result of your immune system being triggered as the mast cells mutate, or is it that the implant starts to leak? And remember, you can get gel leak without having a rupture. So think of it like a tea bag. The tea bag looks fine on the outside, but you put it into water and the tea just leaches out. So over time, there's a degradation of the casing of the implant. And so you can get these little micro perforations and gel leak. Whether that's, and we're not sure. And the problem is that we don't have this magical test yet. We don't have a blood test. We don't have any imaging that we can do to say 100%, yep, you've got breast implant illness. And again, that's why it makes it so hard to legitimatize in the medical field, is because we don't have that test yet. But it exists, and it's a definite thing. And there's thousands and thousands of women now on Facebook in the BII group who have demonstrated that they have the symptoms and the illness, and when the implants are removed, they get better. So just because we don't have that test yet doesn't mean it's not an actual thing. But you can get it at any time, from the time that you wake up to the time years later. And remember, it's insidious, right? It doesn't happen unless you wake up from it, then you kind of know the difference straight away. It's insidious. So, you can't tell the difference from today to yesterday to even a week before. But when you look back a year, it's like, gee, I'm really different from what I was last year, because everything creeps in. The joint pain sort of creeps in, your headaches kind of creep in. Oh, why can't I tolerate the foods that I used to have? It's very slow. And so that's why it's sort of hard to put your finger on it.
And like you said, there's so many other factors. If you're waking up from anesthesia and you just had surgery, then, of course, there's a lot going on then. And if it's a number of years later, if there's hormonal changes and things like that. So I can definitely see where making the diagnosis is challenging, but it's great that you have developed this questionnaire, which we'll definitely link in the show notes if you're able to share that with us, because I'm sure people would love to see that. And what about saline implants? Are those safer, or can people still get BII with the saline implants?
People can still get BII with saline implants, but we don't insert them as often, especially in Australia, as silicone implants for cosmetics and even for reconstruction, to be fair. So we have a reduced number already. So it's hard to make that estimate, say, okay, if 95% of the population have gel, then if you're going to manifest the disease, it's easier to see with a larger group of people. But I've actually had patients who have saline implants, where after 20 years, the casing has degraded enough that there's bits of silicone that have gone to the capsule, gone outside the capsule into the lymphatics and ended up in the lymph nodes. But there was no rupture, because you can see a rupture very easily with the saline implant. It just deflates very quickly. So there's degradation enough that the silicone moves. Now, once it gets to the lymph nodes, it's been demonstrated that it can actually go beyond. So autopsy studies have shown that you can get silicone in the brain and the spinal cord, colon, kidneys. It moves. But we don't have any long-term data or research to show what is the long-term consequence of that. Does it sit there? Does it do nothing? Does it integrate itself? Although I can't imagine silicone in your brain being good. And does it set up local and systemic inflammation? And we know that inflammation is a big driver for cancer. So I'm not saying that people who have silicone in their bodies that's going to go into the lymph nodes or beyond will get cancer. We don't have that as a research proposal yet, but it's in our minds to know this is not necessarily inert, and it doesn't necessarily stay local. What happens when it goes beyond?
And what about autologous fat transfer?
So autologous fat transfer, it's your body, it's your tissue. There was a suggestion early on that for patients who have breast cancer, that it can be a source of stem cells and aggravate any particular breast cells that want to convert into cancer cells, can aggravate that. But that's been debunked. And we do use it for patients, whether they're cancer patients or not. So we consider it very safe.
And you've mentioned rupture and leakage already, which we know are very important. Are there certain things that contribute to rupture or leakage, like certain exercises that people might do? I know one of the listeners asked about mammograms, if that's something that might increase the risk of those events.
That's a very tricky question because you want to do your mammograms and your ultrasounds to rule out cancer. But at the same time, we know that if you have breast implants, there's a very small, I think 1% to 2% chance there may actually be a rupture during that time. Yeah. So we still encourage women to have mammograms because there's ways of actually pushing and manipulating the breast and the implant to get out of the field. So you just need to go to a reputable place that does it very consistently with high level of expertise. I've never seen it. I work at Bluestein as part of my oncoplastic job. We never actually had any rupture. But anything with significant force has the potential to do so. Now, these implants are tested and they go through quite a strenuous amount of torsion and pressure, and they still remain intact. I don't think it's actually the exercise that's causing the issue of breakdown and gel leaks and sort of the degradation of the capsule. I think it's your actual immune system trying to break it down and weakening the actual device. So I haven't seen anyone, I've never told anyone, look, please don't exercise because you've got implants. I think that we're counterintuitive. I tell them, of course, after reconstruction, just be mindful, don't do too much. But no, there's nothing to say that you can't exercise or do the chin-ups and the pull-ups and everything related to the upper chest. But remember, mammograms are very important. They do not increase the risk of cancer. The level of radiation is actually equivalent of you having a flight from Sydney to LA a few times back and forth. And I don't know of anyone who would have cancelled their holiday just because of the background radiation. And the good thing about mammograms, it will pick up calcification. So you can try doing CTs, you can try doing MRIs, you can also try doing ultrasounds, but it's usually the mammograms that pick up calcifications, which can be a sign of precancerous change, such as DCIS and or invasive cancer. And we know that with any type of cancer, the earlier you pick it up, the better your outcome is in terms of treatment.
Do you see very many patients with hypermobility as part of the breast implant illness picture?
Yeah, I do. I do. And so as I start to go into it and learn about mast cell activation, and I'm part of the masterminds group who are very, they're very keen to know about everything, I started to realize that BI actually, in most people, come as a syndrome. So mast cell activation, many people have polycystic ovarian and endometriosis, irritable bowel. And irritable bowel is probably the most nuisance term possible because it doesn't describe much. But I have actually taken biopsy samples from previous scopes and shown there's elevation in mast cells in the scope samples, in the biopsy samples. So this IBS that they're talking about is most likely related to too much of the mast cells in the gut samples, as well as too over-triggered and release of histamine, which then causes a leaky gut and so forth. And then we've got hypermobility, we've got POTS and ADHD type symptoms. So the more that people tick these, the more likely that they're going to have BII. And I think it wouldn't be so far-fetched to take these as part of your screening for anyone who wants to get implants and say, do you have any of these? Do you have even mild symptoms of ADHD and POTS? Do you get palpitations? Do you get tachycardia? Do you feel dizzy when you stand up? Just a general screen and say, look, you've ticked a lot of these boxes. The likelihood that you're going to get BI is probably higher than other people. Now, this is on the proviso, though, that they have these symptoms to begin with, because many people might have such a mild case that don't meet the criteria for irritable bowel, for example. But then they put them in and the IBS gets, the symptoms of the gastrointestinal digestive issues get so significant that they develop an IBS. So you might have a very low grade or very insignificant symptom, when it comes to the disease, but then when you put them in, they get worse. And that's when you actually identify. But we have many patients who, are hypermobile. But I have to say that and I think we'll leave it to the end because I know you're going to ask me a question about hypermobility, and I'll leave it to that. But it's very important to take a really good history for these patients. It's not a case of you coming in and in 10 minutes we're going to talk about taking your implants out and getting out. A consult's usually about an hour, and I'll go through what were you like from the time that you had your implants put in, what you were like after that, when did the symptoms come, what did you recognize first, and then I go through the list of the things that we talked about. Do you form that syndrome? Because again, we don't have that test, and I can't assure anyone that they're going to get better, but the more that they take, the more likelihood that they have BII and the more likelihood that they're going to get better afterwards. But certainly hypermobility is a big issue. And with that comes connective tissue problems. Do they have epigastric pain when they eat? Do they fall into mals? Do they have, kinking of the vessels up near their neck and shoulder that causes occlusion, that causes tingling of the fingers? Very, very common to get these outlier symptoms against which other specialists go, you got tingling in your fingers, you're hyperventilating. It's your anxiety, right? No. It doesn't go that way. And, I read a paper, and it still makes me livid to this day, that there was 4 parts to it, and the final conclusion came out that the type of surgery doesn't matter, but more to the point, these patients are neurotic. And it's a US-based plastic surgeon, and she actually wrote, and if you give me just a brief moment, I would love to read this to you because I think it shows the level of scrutiny that we go through. So essentially it says that females who have BII have high anxiety levels, depression, anxiety, they have personality traits of neuroticism, the ongoing tendency to experience negative emotions, also higher in this group of people. Then they go on to say social media platforms aggravate that, and they all come together, and so they're all hyperneurotic, and they can't explain this unpleasant feeling. But once they get the implant out, that anxiety settles because it's all in the head. I'm summarizing, but that's essentially what it is, right? Now, what this author doesn't understand is that anxiety is the result of the BII. It's not that the patient is naturally or innately hyper anxious or neurotic. It is because nerves and mast cells are very heavily integrated. They oppose each other. And so when their mast cells are triggered, and they can be triggered very instantaneously, histamine release is very fast. They release it directly onto the nerve. And when you're directly onto that nerve, you get a very instantaneous fight or flight response. So you get a background of anxiety, but then you get this panic attack, or you get anxiety or depression. No matter what it is, it's a direct relation of the mast cell against the body of the neuron. So it's the result of the breast implant illness. It's not innately for the patient that she has some psychological issue in most patients. So you're missing the point. Now, when you remove the implant and the capsule, which has some silicone in it, you have now calmed those mast cells down. And therefore, that is the reason why your anxiety settles. There may be a component also of relief that your implants are gone, but it's not 100% of the reason. It's a molecular understanding of immunology. And I think it's really irresponsible for a plastic surgeon who's supposed to be looking into breast implant illness to then switch around and say, you guys, you're neurotic. It's in your heads, you go into the social media platforms and you just hype yourself up. It's not like that. Where do patients go if your doctor tells you it's in your head and you know that not to be true? You go to social support. And your social support comes through social media these days. You get hundreds, thousands of women who can come together and say, I've got that symptom. You've got that symptom. Maybe there's something here. Now, are you telling me those thousands of women are all neurotic? They all have mental health illness? No, no, no. You have to look at it in the true context. And the true context is you have breast implant illness, your nerves are activated by the mast cells releasing histamine and many different factors. You remove the implants, which does have a level of relief to the patient psychologically, but more importantly, your mast cells settle down and then you don't activate your nerves so much to become anxious and have panic attacks and depression.
That drives me crazy. Also, that's like insane what you just read. And what bugs me so much about that is what happened to believing the patient, until they give you a reason not to, right? Like we're supposed to listen to them and believe them. And that plastic surgeon obviously does not, which is just insane. And another thing that you mentioned in there that I wanted to come back to was you said that that plastic surgeon said the type of surgery does not matter. Um, does the type of surgery matter?
Yes, it 100% matters. Um, so the paper that they did, unfortunately, is not very robust. The numbers are not there, and they didn't actually analyze the patient's different surgical techniques for those patients who had BII, whether they had exactly the same implant type, whether they were ruptured, how many silicon particles were in there. They look at it from people who had BII, did not have BII, and the control group, but they didn't actually analyze within the BII group. Now, they also didn't understand that, they came, I think it was a very low 4% of patients had silicon in their capsules despite a no rupture. But we are seeing in our group at least an 85% amount. So 85% of our patients will have silicon in their capsules despite no rupture. So I'm not sure where they're getting this low percentage of, but I can guarantee you it's much more than that. We have a significant amount of patients who actually have explants by other surgeons. No capsulectomy, some capsulectomy. And I can tell you those patients may have an improvement in their symptoms, but not to the maximum that they can have. Also, some people have very limited amount of improvement. And so we go back and take out the tissue, the capsule that has been left behind. And that's when they start to improve. So my question is, does this author believe that the capsule is pathological tissue? Because if she says no, this is not a pathological tissue, I would say, well, we often see acute and chronic inflammation in these tissues, with or without silicone. Inflammation as part of the tissue continues on despite the fact that the implant has been removed. And as you know, when you have inflammation in one part of your body, it can be recognized as a systemic symptom. So, and if you are saying that the capsule is a pathological tissue, then why aren't you removing it? Now, there was another podcast by another plastic surgeon from Texas, and she said, this is not a unique skill to have. Any plastic surgeon can take out capsules, whether they're under or over the muscle. Then why aren't you doing it? If ALCL, the lymphoma that's associated with implants, removal en bloc of the capsule is required, and you are capable of doing it safely, why aren't you doing it? We know that this is pathological tissue. We see it under the microscope time and time again, but we don't know who's going to have it and who doesn't. But we say a significant proportion have it. 85% will have silicon. A significant proportion will have acute and or chronic inflammation there. It needs to be removed. And the best way to remove it is en bloc. Now, a lot of people have an issue with the term en bloc. En bloc is used often in cancer surgery, but it just means in totality. In French, it is derived from the term that says in totality, or get it all out. It doesn't mean you're taking half the breast with you. Yeah. It just means take everything out as one, because often we also see fluid, peri-implant fluid. And when we've analyzed this fluid, they have floating silicon in it. So once you breach that cavity, which is still intact, you potentially releasing that silicon to your operating field and contaminating it. And silicon is very, very sticky. You can't just wash and wash and wash and wash, especially with a massive rupture. So take it out all in one. Reduce that as a variable. If patients don't get 100% or, we aim for about 90 to 95% better, then you have, okay, I've removed the variable, which is the silicone. We need to now concentrate on the mast cell activation. Do they have mold issues? Do they have something in the home? What are they sensitive to? But if you don't remove all of the particles and without a doubt that you have nothing left surgically, you don't know what you're doing. And as pathological tissue is the same as in BII, is the same as in cancer in my mind. I'm not leaving cancer behind. Why would I leave pathological tissue of a capsule behind? So I'm very adamant because we have a very high success rate on people getting better. 98% success rate.
Wow.
Of 85% resolution of symptoms. Now, the paper that talked about it doesn't matter whether they have a full en bloc, whatever, capsulectomy, they accepted improvement of their symptoms when it was 10%. So the
Oh my
patient had
gosh.
10% improvement after the surgery. They counted that as a win. Like, that's not a win.
No, definitely
It's probably
not.
just because they had pain from the implant that had, captured the contracture. That's not a success. So you have to read these papers very, very carefully and understand what they're trying to sell you. And what they're trying to sell you is you're crazy if you're thinking that the operation matters. Those surgeons who are doing it are irresponsible. You're increasing the risk of chest wall injuries and lung injuries and heart injuries, which we've never had, because you go slow. Go slow and take your time, and it takes hours and hours, but you get to the end eventually, and people do better.
Yeah. Yeah. And we're going to talk more about the type of surgery and making a diagnosis of BII and a bunch of other things. We're going to take a quick break and we'll be right back. This episode of the Bendy Bodies podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos syndromes community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. We're back with Dr. Nagy, and this is such important information. And you were just talking about the differences between subtotal capsulectomy and en bloc resection, and that some people say, oh, well, you might get a lung injury or something like that. And I think it's important for some of the listeners to maybe understand that the breasts are on top of the chest wall. And so when some people say, oh, well, you might get an injury, if you're, like you said, if you're not going carefully enough, that, there theoretically could be a chest wall type of injury, but you're going slow and you're taking your time. Are some surgeons not doing that because it's quicker and easier to do the subtotal capsulectomy?
Of course, it's much easier. You're only taking half or some of the capsule. So if it's on top of the muscle, there's no reason, even if you don't feel confident that, you find it too dangerous, for example, in your hands, there's no reason not to do an en bloc when it's on top of the muscle, because you have a good thick layer of pectoralis major on top of the chest wall. So let's remove that out of the equation. Now, when it's underneath, the capsule is actually firmly adhered to the periosteum of the rib and the fascia of the intercostal muscle. There is probably only a few millimeters from the capsule through the intercostal muscle to get inside the chest cavity, and that's where you have your lung and your heart, which is why we take so long to do it, and I wear loops that magnifies everything. We go slow and to take everything out as one. Now, is there a theoretical risk, especially if it's really, really stuck, very inflamed, really contracted, thickened? yes, there's a theoretical risk that we can cause a lung injury, a chest wall injury. And I give my patients a less than 2% chance that would happen, because anything can happen in surgery, but that's why we go so slow and take hours and hours to do it. Now, the other thing is you need to be under the hands of someone who knows what to do if you have a chest wall injury, how to repair it. If there's a lung injury, have they had trauma training as a general surgeon, cardiothoracic training to know how to put in a chest tube, how to manage it while you're sleeping, what to do post-operatively. And, we have patients coming in to say, my surgeon told me that if everyone had an en bloc, half the ICU would be admitted by them because they would have lung injury, right? So that's really scaremongering. Who would want to go into surgery to do this knowing that you're going to have a high risk of lung injury? Right. So I say to people and I say to surgeons, if you're not willing to do it, if you're not comfortable doing it, either learn, upskill, or don't do it and pass it on to someone who actually will do it, because patients do better when the capsule is removed. From a BII point of view, but also from a contracted point of view. So a lot of patients will say, I feel very difficult, like I can't get my breath in. And the mechanics of movement of your ribs is such that it has to open up when you breathe. And when you have capsular contraction with the capsule overlying your intercostal muscles and ribs, it restricts you like a corset. And so unless you remove that, then your ribs can expand and your lung can expand, and then you get that breath in. And a lot of people the next day, they say, I can breathe again. You don't have the same level of release of that restriction if you leave the capsule overlying the ribs and the intercostal muscles. So it has two benefits. But, we've been doing this for quite some time. We're now about 200 patients on. No chest injury, no lung injury, because you just need to do it properly. And if you're not specializing in this, if you just want to put in the implants, that's one thing. But don't call yourself a specialist in BII as a surgeon if you're not willing and capable of doing the work.
And I'm thinking, from being in the operating room for a couple decades, that's pretty amazing if they actually are saying that they feel like they can breathe easier after they've just had this pretty major surgery. So that really speaks to the fact that, there must be quite substantial improvement, because they obviously also have the inflammation and everything immediately afterwards, from the surgery. So that's fantastic that you're seeing some improvement that quickly.
But we also see improvement in the BII symptoms. So remember that the mast cells are not being activated and triggered anymore. So they're releasing this histamine. So when I see them next day on the ward, they're breathing better. The eyes are whiter. A lot of people have injected red eyes. That's also very histamine related, and that settles. And the brain fog. The brain fog releases in many patients quite quickly.
So what should people be asking their surgeon specifically if they're thinking, I'm, concerned or wondering if this might be something that I should pursue? What exactly should they be asking their surgeon in order to determine if they're going to approach this the way that would be most appropriate?
So if they're having symptoms that they can't diagnose, they've looked through everything, they've seen all the specialists, no one can pinpoint anything, and it's sort of outside the square. They've had all blood tests, imaging, nothing is showing up, starts to think about BII. The questionnaire that has been formulated is actually for Lyme. It's for Lyme patients because a lot of the symptoms overlap. So I use that one. Take that test, see how many boxes you tick. Now, it does talk about cellulitis and breast tenderness and all these things, which can still be part and parcel of just being viewed or aging. But things like really significant fatigue, you're not sleeping well, you have digestive disorders, palpitations, difficulty breathing, shortness of breath, it goes through like over 250 symptoms. So the more you tick, the more likelihood that something is up. Now, if you think that you want them out, find a surgeon that will guarantee you will have all the capsule removed, ideally as en bloc, with photos, photographic evidence of the intact capsule over the implant, front and back. Because sometimes they give you the photo of the front bit and then you turn it over and there's a big bare piece missing, and that's the capsule that's remaining on the chest wall. Find someone who's not afraid of it and will guarantee it. Because a lot of people say, "I'll do my best. I'm on your side. Everything. Whatever is safe, I will do." And then they come out with this tiny little fragment, and then they tell the patient it was too dangerous. Well, you knew that to begin with. You knew that you're not going to be able to do it. So yet you took the patient's money and did half the job. Now they have to go find another specialist who's willing to go in to take out the remainder of the capsule if you haven't gotten better. And that's much more extensive surgery and much, much more difficult because the planes are all squished. So confidence in your surgeon is a really big difference, but evidence is also. The capsule needs to be sent off for testing, yeast mold bacteria, looking at inflammation. And I also ask now to do mast cell counts, which is part and parcel of the normal histology that we do, by staining with CD117. You will not see it with a normal H&E stain. That's the usual one that we do to show inflammation, different cells. It will not pick up mast cells. They just blend into looking like other white cells. So you need to have CD117 stain, which stains them browny black. And then you can see where there's increase in number, which is a good indicator that it played a role in your illness.
And I know for GI tissue, we don't know for sure what's the quote unquote normal number. And, you look for this shape of the mast cells and is there clumping and that kind of thing. Do you have thoughts as to what would be a more normal number of mast cells versus an abnormal number?
So we say anything over 20 per high power field, averaged over 10 or the highest of 10. Anything greater than 20 is considered to be consistent with mast cells of the gut or MCAS of the gut. And so we haven't had many patients. We just started doing this, but whatever we had, I think we're up to 10. Every single one of them had mast cells that were raised.
Wow.
And so they were told, when they looked in the H&E, everything's fine. No inflammation, there's no signs of ulceration, no Crohn's, no ulcerative colitis. But when they stained, they're high. The highest I've had so far, and she couldn't eat properly. She was stuck on just a few foods. It was 73. It's well above 20. And so unless you target MCAS medication towards the gut, cromolyn is a good one, sodium cromolyn, just as a mast cell stabilizer, it's very hard to get on top of things. So, when we do the operation, we want to maximize the surgical approach, but there's also some extra things that we have to do in a number of patients to target the mast cells that are still hyper in different parts of the body, such as the gut. But it's very, very difficult and virtually impossible to resolve other parts of the body unless you remove the ultimate trigger.
Mm-hmm.
You're beating a dead horse if you're trying to give many, many different MCAS type medications, but your immune system is completely overwhelmed with having implants in there.
Right. No, that makes perfectly good sense. If the offending, um, foreign body is still in, that it would not be easy by any means to resolve the symptoms. And I prescribe cromolyn sodium a lot as well for gastrointestinal symptoms and topically in a variety of different ways. So if people are maybe they've already had a partial capsulectomy and they do have some remaining symptoms, and you do an en bloc resection, what are the statistics there in terms of percent improvement?
So when we go back in, that's not called en bloc anymore. So that's going to be called just removing the residual. And if they had no improvement, we're seeing up to 60 to 70% improvement in their symptoms, residual symptoms. Those who had, 50%, we might have an extra 20% improvement. But it's the things that really matter, such as energy and brain fog. the things that are really critical to everyday functioning. So we do see improvement, but the problem comes is that what's happened is that you probably have released silicon, and you still would have silicon within the breast tissue. And so that's maybe the reason why they're not getting to the same level as other people who have done it the correct way to begin with. So they need a lot more support in terms of their MCAS, because you've breached that area where it was contained originally, and now it's sort of spread. The interesting thing is that when we have patients who have en bloc, but we know they have silicon in their lymph nodes, they still tend to get better, which is counterintuitive, because when it's in your breast tissue or when it's localized to the breast or even lymphatics, it seems to be aggravating. But when it goes to the lymph nodes, you can still have improvement despite not removing the lymph nodes itself. So Dr. Feng, she illustrated that she used to take out lymph nodes that had silicon within them.
Mm.
And that causes a lot of morbidity. So we have, cancer patients have the lymph nodes removed as part of their cancer treatment. They can get lymphedema, they can get cording, problems with their shoulder, movement, chronic pain. And so you offset the benefit with a lot more morbidity. So then we decided, okay, why don't we just leave the lymph nodes there and see what happens? And actually, patients did get better from their BII symptoms regardless. I've got a patient, she had a massive rupture. Not sure how the surgery went, to be honest. And she's got lymph nodes full of silicons in her axilla, up to her neck, the internal mammary chain behind the breastbone. And she's really, really well. She's had a baby, her first child, about 2 years ago, continues to do well. So there's something in that microenvironment of our lymph nodes, which is somewhat different to when we have silicon within our breast, in the breast tissue or the lymphatics. It's quite interesting.
Yeah, that is interesting. Um, could that be a toxic load kind of a situation where if you removed by far the bulk of it, even though there was some silicone in the lymph nodes, you've reduced the toxic burden significantly enough that they improve?
Potentially, but I think maybe it's also about inflammation. So even though the silicon is within the lymph nodes, when we do a biopsy of that, we don't see inflammation, yet we see inflammation as part of the capsule. But I'm not sure about burden of disease, because this lady has a lot of silicon in a lot of her lymph nodes. And she's got a lot of burden of the silicon within her body, but she's still functioning very well.
Yeah, interesting. Um, One of the listeners wanted to know if you recommend replacing breast implants after a certain number of years.
Yes, I do. So we've seen gel leak without a rupture as early as 2 years after insertion. That's not to say you should be changing it every 2 years,
Mm,
but we know they're not lifelong devices.
mm,
And we keep, the companies that make it say this is cohesive now and it's double layered, or we have new technology. It's fine. You can leave it in there unless you have a problem.
mhm.
Now, what kind of problem are you talking about? Because if you have a rupture, there's a big issue. But even for my cancer patients, I usually start introducing, well, it's a small operation. It's, take 15 minutes. I'm going to take out your old implants and just add a fresh one. 5 to 10 years. Very different from the cosmetic world, I'm sure. But we have to be mindful that these things can gel leak very, very early, 2, 3, 4, 5 years, even after insertion. And we don't know the long-term consequences of that either. So, the standard used to be every 10 years. I think that should still stay. I don't think that, you should be leaving in there, because it's going to degrade over time.
Mm,
And a lot of people say, this is an implant, we'll sit it on the table. If I come back in 10 years, it's going to look exactly the same. And that may be true, but the environment is different. When it's inside you, your immune system is actively breaking it down. And whilst it is not able to do so to completion, you do have weakening and degradation of that casing. So I usually start introducing at the 5 year for my cancer patients, and certainly at 10 years.
And in the cosmetic world, do you know what the recommendation is there?
Well, from what I'm hearing from patients is that don't do anything unless there's a rupture or there's a
Mhm,
problem
mhm.
because they're lifelong devices.
That's what they're being told. Yeah.
That's what they're telling me, and I think that's
Mhm,
quite absurd.
mhm,
You should be looking at least every 10 years.
mhm.
But if you have symptoms of BII, I don't think you should be putting in a new set either because you already primed yourself. If you're not really dependent on your implants, um, and you have significant BII symptoms, that it's a diagnosis of exclusion. Okay, so you've
Mhm,
excluded everything else, and you're still feeling rubbish. The answer is not to put them back in. Find someone who will take them out properly for you. Fix your muscle if it's under the muscle because it's exceptionally important for function and for look,
mhm,
and do some level of reconstruction. Yes, you'll be petite, but what you don't want is wrinkling of the skin, nipple inversion, um, cavitating essentially. You can avoid that. And you can be healthy and look normal and just be petite. There's nothing wrong with being petite if you've if you have symptoms.
and reconstruction is possible, then is that something that, do you know? I mean, obviously, it's gonna vary depending on the person and where they live and what kind of insurance they have, but is this the kind of thing that is sometimes covered by insurance, not often covered? Do you know?
So in Australia, we have a very strict criteria that you can have a lift or mastopexy if the nipple is at the lowest point of the breast and two-thirds of the breast is below the inframammary fold.
Mm,
Then they say yes, it's a legitimate medical need. However, if you don't meet that criteria, it's that part of the operation is considered cosmetic and totally out of pocket. But that doesn't mean the remainder of the operation is. Yeah. So the explant part, the capsulectomy, the muscle repair, the private health insurance, and the hospital, the majority is covered by the health insurance. It's just that, for example, 1 hour cosmetic time that's allocated to the patient. I'm not quite sure of American standards, but it really should be part of it. It's very difficult to come from someone who's got very round and robust, no, sort of busty look to being very petite. But the petite is not the problem, it's the flattening, it's the nipple ptosis, wrinkling of the skin. Because remember, when you were an A cup or B cup, when you put them in and you've expanded to C, D, double D, E, you've done it instantaneously. You haven't given your skin time to stretch. And so when you take them out, tissue turgor is often a problem. Yeah. And you get lots of wrinkling. And when women are young or even if they're older, it just doesn't gel with their psyche, right? When you look at the befores and afters, it's very confronting. So you try to minimize that by doing a lift, you tighten in the skin, um, and you elevate the nipple to a high position. And that gives perkiness, roundedness, smoothness of the skin, um, without sort of the adverse effects of having the stretching. Now, we have to be realistic, and a lot of our patients do have significant body dysmorphia, for example, and they expect perfection, but you're dealing with tissue that has been, um, we call it's not virgin tissue anymore. So when you put your implants in their virgin tissue, it's not virgin tissue anymore. It's been stretched and, and somewhat destroyed by the fact that you had implants, right? And so we're trying to work with the tissue that we have. So we have to be realistic in what we can do, but what we don't want is to be, abnormal in how we appear in front of the mirror.
those are such important things to discuss with the surgeon, and I know when you gave the talk to the mastermind group, which was an outstanding talk, by the way, you had some great images that you showed. Maybe we can put some of those on the YouTube video so people can actually see, what that looks like after the reconstruction, because I think that's such an important thing to talk to the surgeon about if that's something that they can do so that, you can have a good outcome.
Yeah. And like I said, it cannot be perfect.
Right.
We try our very best to minimize the negative effect of the implant that was there. But you shouldn't walk away feeling that you have been deformed.
Hmm.
Yeah.
Yeah.
It's just trying to maintain that normality.
Okay. Well, this has been such a wonderful conversation, and I could ask you so many more questions, but I want to be respectful of your time. And you probably know we always end every episode with a hypermobility hack. So, do you have a hack that you could share with us?
Okay, the hack is not really a true hack, but um, so a lot of people will actually who come into my rooms. If you did the Baden score, that you probably would say that they're not hyperflexible. But actually, what has happened is, I'm preaching to the choir, I'm sure, because you know this, but your muscles try and compensate for the looseness of the joints and become very, very tight. And so if I try to say, okay, bend down and touch the floor without bending your knees, they can't do it. And it's not necessarily because they're not hypermobile, it's the fact that their muscles have tightened up. So I usually go back, and if any patient is thinking, well, I used to be mobile, hypermobile, but now I'm not, go back and think, what were you like as a child? Did you have, did you amuse your friends with contorting your body or into strange shapes, or could you do the splits? As a teenager or a child, did your knee dislocate? Did your shoulder dislocate for doing not particularly anything traumatic? Do you have velvety skin? Is it soft? So just because you don't meet the Baden score doesn't necessarily mean you don't have hypermobility, hyperflexibility. It's just that your body has changed over time to compensate. And so working with a coach, someone who specializes in the field to strengthen your muscles, supporting your joints, the stability, I think you may agree that that's the best approach that you can to try and remedy the situation, even if you don't think that you have the hyper flexibility and mobility when actually you do, and your body's compensated in an adverse way.
Yeah, and we all know that joint mobility goes down with age, so there's even just normal aging and injuries and surgeries, and it is very frustrating because the Beighton score only looks at a small number of joints, so the Beighton score has plenty of flaws, so we talk about that a lot. So where can people learn more about your amazing work?
So we have a Facebook group, a Facebook page where we talk about BII. We've got our website, and with Tanya Dempsey, we've done a couple of podcasts. But I think over time, now that we're getting more and more numbers, we're going to be publishing more. And I
Mhm,
think the next one, so the pilot study that we had 15 in each group. And we did show the mast cells were very significantly different, and doing the on block caused a really good resolution in many symptoms. And unfortunately, it was poo-pooed by journalists who didn't understand the concept of a pilot study and said the numbers were too
mm,
small.
mm,
And so now we're going to be publishing afterwards. We've got 150 plus patients now, and it shows exactly the same thing
mhm.
where, you do the surgery, people will get better from BII. It's a legitimate illness. The mast cells um, is it's the source probably, or the foundation of what the issue is, triggering of the mast cells, activation of the histamine and the rest of your body to cause these symptoms. And then ultimately what we want to do is to have more people and publish on the bowel study to show
Mm,
that the mast cells are increased in number there. And then the third one is, after doing 150, 200 patients, is no chest wall injury, no lung injury, no heart injury. It is safe in the right hands. And I think that patients should try to push for this for their own benefit. And unfortunately, patients have to be their own advocates sometimes,
mhm.
until we have a consensus that this is the right way to do things.
And can you take patients outside of Australia?
Yes, yeah. So
Okay.
we have a lot of interstate patients within Australia, but also we've had a few from America. Um, if money is an issue, Dr. Fang and Dr. Khan are big believers on doing on block locally and within the US. But those who travel, we have a corporate rate with apartments nearby, very close to the hospital.
Mhm.
So we can work with patients to come, and we have had that, yes.
Well, thank you so much for taking the time to chat with me today. I know that you're extremely busy, and this was just such a great conversation. I think the listeners are really going to enjoy, hearing this information. And like you said, this is a legitimate illness, but unfortunately, so many people are led to believe that it's not. So this is just really important information. So thank you for sharing it.
I think women know their bodies, you
Yeah,
know?
they do.
And unfortunately, if you're being gaslit by one person, go see someone else because there are people out there who believe you. And my mother told me, she's a doctor herself, she said, Ava, if you're too stupid not to know that the patient is telling the truth, that's on you. Yeah, figure out what's wrong with your patients. The patients are always right. And don't be the stupid one who says it's just in their heads. And I've taken that ever since I was 18 when I started my training. I've taken that on board, and just to legitimize and understand patients, the vast majority of them do have an issue, and we need to get to the source of it and stop gaslighting and blaming your patients that they have a mental illness.
Absolutely. Wonderful words of wisdom from your mother. That's amazing.
True.
Yeah, yeah. All right. Well, thank you again. I really appreciate it.
Thank you so much.
That was such a great conversation with Dr. Nagy. Mast cell activation syndrome affects so many of you, and so this is such an important conversation to have. Thank you so much for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. If you'd like to dig deeper, you can meet with me one-on-one. Check out the available options on the services page of my website at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, and LinkedIn at hypermobilitymd. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.